From the RSNA, welcome to the Radiology Imaging Cancer Journal podcast hosted by the Trainee Editorial Board. I am Yashvir Singh from Mayo Clinic. We wanted to highlight the ongoing special collection we have. The neuroradiology head and neck collection will be concluding soon, and we will be launching the pancreatic hepatobiliary one next. Dr. Srinivasan is editor in chief for the neuroradiology one. Lassie and Pallavi are leading the pancreatic hepatobiliary collection with the help from Dr. Luke on the interventional side. Today we will continue exploring the this year's RSNA theme in imaging the individuals with our special guest Dr. Ashok Srinivasan. Dr. Srinivasan is a professor of radiology and associate chair of operations, quality and safety at University of Michigan, where he previously served as a director of neuroradiology. He is actively involved in research utilizing advanced imaging technology, including diffusion and perfusion imaging and artificial intelligence. He has published over 170 papers and written 8 book chapters. He served on the editorial boards of premium radiology journals, including Radiology and European Radiology. Is radiology editor for JAMA, deputy editor of Radiology, Imaging Cancer, and past associate editor for Neurographics. A frequent speaker at national radiology conferences, Dr. Srinivasan served as ASNR International Outreach Visiting Professor to Thailand in 2017 and Brazil 2020. He has served as the president of American Society of Head and Neck Radiology, president of the Western Neuroradiology Society, and as a chair of ABR Core Exam Committee for Neuroradiology. He received the RSNA Honored Educator Award in 2023 and 2024 and the Fellowship of American College of Radiology distinction in 2021. To start, can you tell us about your journey? How did you get into neuroradiology and what led you to focus on imaging research?
Well, thank you very much for allowing me the opportunity to speak to you today. Just to give you a brief background, my training started in medical school in India in a place called Madras Medical College, where I pursued my original medical degree called MBBS. Subsequently, I did a radiology residency in New Delhi in an institute called the All India Institute of Medical Sciences. And I was interested in pursuing fellowships. And my two options at that time were either I wanted to do neuroradiology or pediatric radiology. And I interviewed in multiple places. And I got matched into both neuroradiology and pediatric radiology at different places in Canada. And I chose neuroradiology because I think I had a slightly more preference or inclination to go into neuro and the exciting aspects of being able to look at brain related clinical issues as well as brain related research. So I did my fellowship in the University of Ottawa in Canada and then subsequently moved down to University of Michigan where I've stayed for the last 20 plus years. And during this entire journey, I think I had something very critical and people don't appreciate it much. That is, you need to have excellent mentors who inspire you. And I had excellent mentors in my residency as well as my fellowship who showed me that your clinical work can become mundane. But if you treat every case that you read as an opportunity to improve patient care, a research question will automatically come up. So that was my motivation to pursue research. And then obviously during the course of research, you're automatically interacting with a lot of residents and fellows on a daily basis. So you enjoy that educational environment because you might be thinking something is, again, routine day-to-day work, but a resident might ask you a very pertinent question and that can get you stimulated. And that can feel like, oh, this might be a good research question. And let me give you one example. So we all measure descent of the cerebellar tonsils beneath the foramen magnum, and we call it like sometimes Chiari deformity, Chiari malformation. But I realized that everybody is measuring it slightly differently. So on the same patient, they are giving different values. So one person says 5 millimeters below the foramen magnum, the other says 7 millimeters, even though the measurement is the same. So that was the genesis of a project looking at where can we use landmarks to reduce that inter-observer variability. So that was a really long-winded answer, but I hope that gave you a glimpse into my initial foray into this domain.
Yeah, that's very interesting journey you have. So, being as a deputy editor of radiology imaging cancer, you review cutting edge research regularly. What distinguishes truly impactful imaging research from work that simply gets published?
There are lots and lots of papers, and they usually have said, and this was our data that I got many years ago, that the medical literature doubles every 5 years, and probably these days it's probably a much shorter time frame. Now, the basic problem that we have distinguishing what is impactful research from what gets published is our ability to actually look into the details of those papers. So many of the papers I look at, the first thing I am trying to assess is what is the clinical impact of this particular project? How is it going to alter management of patients? Will it change the diagnostic certainty with which a radiologist is able to talk about a particular condition? Will it give them a better idea about suggesting future follow up studies? And a good publication also needs to articulate clearly what are the future steps. So you might have a great idea, you might have great results, but if you do not articulate what is the eventual outcome from that publication, I think that's a deficiency that some authors do not get. The ability to clearly articulate future steps, I think, should be a part and parcel of all types of research, and truly impactful research will usually have a timeline laid in there, or will have a framework for I did this project, I got success, but this is what we need to do. It's not sufficient to say future studies will look at this. That's a very easy way out. We need to say look at what aspect to determine what type of outcome.
So now, when you are reviewing manuscripts or mentoring early career researcher, what common pitfalls do you see?
See, the commonest pitfall that I see in an early career researcher is they are sometimes over ambitious. They have excellent ideas, but they try and cram all those ideas into one paper. So, what happens is there are too many aims or specific aims in that paper, and the data that they collect and the analysis that they do is not sufficient to prove each of those aims adequately. So, you need to realize that you are building a big tree. That's your research tree, and you need to build it with smaller branches first. So it is okay to have a project which looks very simple to you, but if your aim is specific enough and focused enough, that will give you greater success in the long run. Also, you need to carefully consider what is the clinical impact of your study before you plan the study. So, if you're doing a study and that is purely for academic purposes and it never is going to find a clinical impact, then you might have to rethink your strategy, because whatever you do in this type of research should eventually translate into better patient care.
So nowadays, AI papers are flooding in radiology journals. As someone doing AI research yourself and evaluating these submission, how do you distinguish genuine advancement from work that's just riding the AI wave? I just wanted to know your perspective on that.
See, this is a wonderful question. So, thanks for asking it, Yash. And this is a difficult question as well. So, my personal perspective on what AI work should be is multiple fold. Let me start with a couple of them. One, anything that we do to incorporate AI into our daily workflow needs to improve our efficiency and improve our accuracy. While that sounds straightforward, let me give you some examples. we have a lot of tools now that are doing qualitative and quantitative volumetrics. And it says, oh, it's going to cut down your time for interpretation. You don't have to sit and measure things. However, we come across multiple instances where the automated generation of a volume, say within the brain parenchyma, is not concordant with what you are actually seeing on your own images qualitatively. So we often end up overruling it. So it's actually costing us more time to use that AI tool. So efficiency and accuracy needs to be at its highest possible for any AI tool to help radiologists. Now, the third thing which I really think is missing is the practicality of its implementation. So the genuine advancement will only come when you can easily implement that AI tool, easily embed it within your daily structure without causing too many downstream effects. Because if your AI tool, for example, detection of intracranial bleeds, is going to have too many false positives and too many false negatives, then you are ending up spending more time overruling those AI algorithms. So we need to have tools that are essentially creating a much better work environment for us and also being able to provide as accurate an workflow as possible so that work doesn't feel like work.
Yes, so if we have a high quality AI research that meets those standards, the next hurdle is implementation. As someone bridging research and clinical operation, what's preventing promising work, whether AI or advanced techniques like your diffusion and perfusion imaging, from actually changing practice? Wanted to know your views on that. What is the gap between the publication and the adoption?
This is a really good question because this brings into the limelight what humans are famous for. We want instant gratification. You did something, oh, you do. You want to get the results of that right away. So, to give you one example, the diffusion weighted sequence, even for detecting acute stroke in brain MRI, was actually invented in the 1960s. But obviously, we didn't even have much of MRI based stuff. Wait until the 2000s, we did not have strong enough gradients to be able to do clinical imaging with it. So, the first hurdle to adoption is going to be, do we have technology that is widely available to be able to implement any of these technologies? Second, when we do have that facility to implement these, do we have good amount of standardization? So if my diffusion imaging and my perfusion imaging is only able to help me at my institution, and when you are trying it, it's not really helpful to you, that means there is something wrong. There is something wrong with too much of variability between these implementations. So we are trying to get to a relative standardization of these techniques so that they can be universally adopted. Third is, many of the studies that we publish in AI as well as in advanced techniques, they tend to be studies with relatively smaller sample size. So while it works well at one institution, might work well at a second institution, it's difficult to know right away whether it is going to be globally applicable or not. And for that, you can say, why don't you just do larger studies? And that's a very difficult thing to do. So a better approach might be to do multi-institutional collaborative studies where each individual institution can potentially recruit a relatively smaller number but combine the data at the end, or take another approach which is do a very robust type of systematic review and meta-analysis. So I think there are definitely hurdles, but there are also potential solutions. The last but not the least is we need to have patience while implementing these in clinical practice. And I'm going to tell you one interesting bit, which is, while we're talking about incorporating perfusion imaging, there's not a great deal of level 5 evidence for incorporating perfusion imaging in, say, brain tumors. However, multidisciplinary tumor boards have moved way past that. They are only looking for level 3 evidence that we currently have in the literature, and it's already part and parcel of routine discussions at tumor boards. So, no tumor board in brain tumor boards is completed without discussion of the perfusion images in addition to the conventional images. So, they're kind of ahead of the game on this one.
So, given your editorial perspective, research experience, and leadership role, where should imaging research focus is energy over the next decades, what would you prioritize to ensure research translates to better patients' outcomes?
See, this is again a very fantastic and broad question. So, my perspective is we need to have research that proves the value of that particular imaging technique or imaging algorithm in the healthcare chain, which essentially means how does it really impact the patient management? And we need to be able to do so at an appropriate research utilization. So, if my technique is great at distinguishing two types of brain tumors, but it takes 1 hour to do my scan, that is not practical. And that is going to utilize a lot of resources to get those patients on the magnet and so on. So, our focus should be to prove the value of what we provide, which is imaging based information with appropriate resource utilization. And this, I believe, can actually lead to a more individualized care platforms. By this, what I mean is, say you have a patient who's coming in for a brain tumor or a spinal cord tumor or a head neck tumor. Once we do the scan and apply these techniques, we should be able to even say what is the time interval for the next follow up based on what we are assessing from the current scan and prior scans. Because right now there is no literature on this one. So everybody is blindly using what their institution does. If a particular institution says you need a 6-month follow up, they're following it. Another institution, it might be a 1-year follow up. There's really not a lot of evidence for this. But I think we can prove our value by actually optimizing even what the intervals of these follow up scans should be.
Finally, is there any personal message or advice you would like to share with the radiology research community, especially those just starting their research journey?
Absolutely. And that's again a very pertinent question. So I have used this quote in a few prior talks that I've given. So, which is every medical miracle that we know of today, every new pharmaceutical agent that has changed patients' life, everything started with a small idea, which probably resulted in a pilot project. So, never think that an idea that you have or a study you are about to do is too small to pursue. It all builds up. So, the ocean is made up of billions and billions and billions of drops. So, you are contributing to the overall research environment by using your drop wisely. And hopefully, that will all accumulate over a period of time with your own research and the research of your collaborators at other institutions to make meaningful impact for patient care.
Thanks for spending time with us today. Special thanks to our guest, Dr. Srinivasan, for his valuable insights. If you are enjoying the conversation, please rate, review, and subscribe wherever you are listening. Your interactions helps more listeners find the show. Check our radiology imaging cancer. Link to the journal will be in the show notes. Today you heard from our team. Special thanks to our editor Kelly Myers. We will see you next time on the Radiology Imaging Cancer podcast.